Hi all. Today's class is about retreatment in endodontics. So these are the points we are going to discuss today. Definition, classification, endodontic failures, endodontic success, evaluation of root canal treated teeth, factors affecting the retreatment, objective of retreatment, treatment procedures. Coming to the definition for retreatment, it's an attempt to rectify unsatisfactorily completed treatment. That means any unsatisfactorily completed treatment, be it symptomatic or not, and it's an attempt to rectify any unsatisfactorily completed treatment. The present definition states endodontic retreatment is a procedure performed on a tooth that has received prior attempted definitive treatment, resulting in a condition requiring further endodontic treatment to achieve a successful result. So this may be as part of a failed endodontic treatment, which is symptomatic now, or may not be a symptomatic case. It's maybe an asymptomatic case, but requires the retreatment, maybe due to a later finding that the root canal treatment is not complete in the complete sense of successful treatment. Coming to the classification, the first one says that this classifies as the first point as classified as discontinued treatment by a prior dentist. Second one, incomplete treatment. Third, complete but inadequate treatment. Fourth, complete and apparently adequate treatment but with questionable long-term prognosis. Coming to the endodontic failures. Endodontic failures causes has been described by Grossman in 1972 like the following headings: poor diagnosis, poor prognosis, technical difficulties, careless treatment. That is endofailures due to poor diagnosis, endofailures due to poor prognosis, endofailures due to technical difficulties, and endofailures due to careless treatment, which accounts for about 76%. Whereas another researcher, Crum, listed the endodontic failures in an acronym poor past concept. Poor past, each letter denotes. P stands for perforation, O for obturation incomplete, again O for overfill, R for root canal overlooked, P for periodontal disease, A another tooth, S for split tooth or separated file, T trauma or tough teeth. So these letters, or in the poor past, each letter denotes different conditions which can lead to endodontic failure. These are the major reasons cited for endodontic failure. It can be a perforation or incomplete obturation, over obturation, root canal missed or overlooked root canal, periodontal disease leading to the failure, and another due to another tooth, split or separated file, then trauma or a tough tooth teeth to treat. Seltzer attributed endofailure due to local factors like infection, poor debridement, excessive hemorrhage, mechanical and chemical irritation, incomplete and overextended root canal filling, broken instrument, perforation. So these were the reasons attributed by Seltzer for endofailure: infection, poor debridement, excessive hemorrhage, mechanical and chemical irritation, incomplete and overextended root canal filling, broken instrument, perforation. So how will you define the endodontic success? What are the factors to be counted a case as a successful tooth that has been endodontically treated? So coming to the endodontic triad, it is given as sterilization plus debridement plus apical seal, which leads to success. sterilization plus debridement plus apical seal. These three triads together constitute the success. Success or failure can be divided into three categories. Factors that will influence the success or failure in all the cases, factors that will influence the success or failure in a particular case, and factors with little influence. So let us see this in detail. The factors in all cases: radiographic interpretation, anatomy of the root canal system and the external root, thoroughness of debridement and apical level of instrumentation, degree of apical seal at the cementodentinal junction. So these are the factors that determines the success in all the cases that are endodontically treated. First of all, radiographic interpretation. So the radiographic interpretation is very important, and likewise the anatomy of the root canal system and the external root. So definitely the anatomy of the root canal system is going to be an important factor in determining the successful treatment. The more complex the root canal configuration, the more difficult it is to treat. Thoroughness of debridement and apical level of instrumentation. The most important point: thoroughness of debridement and apical level of instrumentation. Few researchers say that there are most number of failures result in failure of apical level instrumentation at a distance of 2 to 3 millimeter from the apex. So if you fail to do cleaning and shaping procedure or thorough debridement 2 to 3 millimeter from the apical area, it is likely that your case has a greater failure rate. Then degree of apical seal at the cementodentinal junction. So your tightness of your apical seal at the CDJ also determine the success rate of your case in all the cases. Factors in all the cases, again, degree of coronal seal and the quality of the coronal restoration. Just like the apical seal, the degree of coronal seal also determines the success rate in your case. Then asepsis of treatment regimen, and asepsis is very important factor. Then health and systemic status of the patient. This is one common factor for all the cases. Then operator skill and expertise. It's needless to say, operator skill and expertise is going to play a crucial role. Then factors in a particular case: pulpal status of the tooth. So for certain tooth, the pulpal status or the infected status of the tooth determines the success rate. How far it has been diseased, how far it is in a retreatable position. So the pulpal status and the procedural accidents like perforation and instrument separation. So this also affects few particular cases: procedural accidents like perforation and instrument separation, especially in few teeth which are very difficult to treat. This factor is very crucial. Then crown or root fractures. If there are crown or root fractures, again this is going to affect your treatment success. Periodontal status or a disease process. Along with the pulpal status of the tooth, periodontal status or a disease process, ongoing disease process, this is also going to determine the success of your treatment in a particular case. Then occlusal discrepancies and forces. If there are any occlusal discrepancies, this may be particular to a case, resulting in its failure. Occlusal discrepancies and the forces acting on that tooth. Size of periradicular rarefaction. This is another feature. Fact: size of periradicular rarefaction. Then patient's pain threshold. Obviously, the patient's pain threshold is a factor. It's a crucial factor. If the patient is having a less pain threshold, it's very difficult to do the treatment exactly in the way the operator plans. So again, there can be some compromise in your case. The level of your treatment, level of canal fill over or under obturation. So this is again going to be a very factor. It's very obvious that if you over obturate your canal, there can be failure and your symptoms can arise, pain or inflammation can arise. Whereas if your canal is under obturated, again, if that under obturation is followed by under instrumentation, that area remains infected, or the under obturated area later can get infected, which can obviously lead to failure of your case. Time of post-treatment evaluation. This is also another factor following your completion of your treatment. When to evaluate your case after your treatment is over. So that's also a factor particular to a case. Degree of canal calcification. Again, if there are some canal calcification, and depending on the degree of canal calcification, again, if you are not able to negotiate it in the apex of your root canal, again, this can be another reason for failure of the case. Then accessory communication. Accessory communication, lateral canals, again, this can accessory canals, this can lead to failure of your case. Presence of root resorption, that is very evident. If there is any presence of root resorption, again, this can lead to the long-term prognosis of your case. This can affect the long-term prognosis and the success of your case. Now coming to factors with little influence: age and sex, tooth location, cause of pulpal injury. So these factors basically are said to have very little influence for the success of your case. Now about when to evaluate the treated tooth. So when you want to evaluate, when a tooth which is endodontically treated to be ideally evaluated. So the ideal time for evaluation is said to be 4 months after your treatment up to a period of 4 years. Ideal first recall visit should be after 6 months. So that is a most ideal recall visit after 6 months. So even if there had been a chance of incidence of periradicular rarefaction and resorbed periapical resorbed areas, it takes 4 to 6 months time for the healing period. For a minimum period of 4 to 6 months it takes for the bone remodeling and the healing process to occur radiographically. So ideal first recall visit should be after 6 months, whereas the final recall visit should be 4 years. So up to 4 years, if you evaluate and if you find your tooth is asymptomatic and there are signs, healing signs on both the radiographs and clinically, then you can evaluate, you can count it as a successful endodontic treatment. Methods for evaluating the success or the failure are clinical examination. By clinical examination, by radiographic examination, histologic examination. The third method is still in a status of research work ongoing. Bender and Associates outlined the clinical criteria for success as absence of pain and swelling, no loss of function, disappearance of the sinus tract associated with it, no evidence of soft tissue destruction, including probing defects. So Benner and Associates has outlined the clinical criteria for success if the treated tooth is showing these points: absence of pain and swelling, if there is no loss of function, that is your tooth still can function in the desired way, and disappearance of the associated sinus tract after the treatment. Then if there are no evidence of soft tissue destruction, including probing defects, including any lack of any probing defects, so all these things constitutes together, it's a successful criteria for a root canal treatment. Now coming to radiographic findings, each case can be classified as success, failure, or a questionable condition under the following headings. Success: absence of a periapical lesion after 1 year of treatment. So when you evaluate your treated tooth radiographically, after 1 year, absence of apical lesion after 1 year of treatment shows a successful treatment. Whereas failure, persistent or development of periapical pathosis after 1 year of treatment shows a failure case. Whereas neither the periapical lesion neither worsen nor improve after 1 year of treatment. It's still in the same state. So that's a questionable condition, whether you cannot predict whether it's going to be a success or failure. Whereas the complicating factor, error during interpretation of the radiograph still persists along with these factors. So all these, so you can categorize based on these 3 factors, but still there's a complicating factor: error during interpretation or judging the case by your radiograph. This radiograph still exists. That's a complicating factor for the above said points. Now coming to the last method, histological examination. Histologic assessment of success and failure is meaningless in clinical endodontics. So there are several reasons for that. Histological assessment is not so stable or a reliable one to count a treated tooth as a successful treatment. Histological success depends on the reconstitution of periapical structure. So basically, how we evaluate histologically is based on the reconstitution or remodeling when it comes to the periapical tissues, reconstitution of periapical structure that has been destroyed. Then absence of inflammation, all these things. So since routine histological evaluation is not possible, you cannot count histological examination as a successful criteria for counting as a successful treatment, because you cannot rely on the reconstitution of periapical structure because it takes a bit time. Sometimes it can take a longer time for reconstitution of periapical structure. Still it be in a healing condition or in a healthy status. So you cannot rely on this fact. And likewise, routine histological evaluation is not possible also for the periapical area. So these rely more on clinical. So due to all these reasons, clinicians tend to rely more on clinical findings and radiographic findings rather than histological examination. So you can consider retreatment in the following conditions. The first one is based on the patient factors: affordability, time, motivation, functionality. So first of all, it should be your retreatment should be affordable for the patient, and there should be enough time for retreatment. You should not do it in a hurry. Then motivation. It is better to go for a retreatment only if the patient is motivated for the retreatment in the right way. And next, The functionality. If the tooth is not going to be functional, there is no point in going for a retreatment. Whereas the operator factors, time availability is still, that should also be a criteria. No operator factors, there should be sufficient time for retreatment. Armamentarium, sufficient armamentarium should be available with the operator. And third, but the most important is expertise for retreatment should also be there as an operator factor. Now, considering the clinical condition, obturation material is one factor, obturation extension is another one, iatrogenic factors, then canal configuration. So you have to take into consideration all these conditions: obturation material, which material has been used, and obturation extension, how far it is obturated, is it under obturated or over obturated. Then iatrogenic factors, if there are any irreparable iatrogenic factors, that should also be understood. Then canal configuration, is it a if it is a very difficult canal configuration, so again your case may not be a success if you go for the retreatment. So all these factors has to be taken into consideration: patient factors, operators factors, clinical condition. So what's the basic objective for retreatment? So it is to perform endodontic therapy in order to return the treated tooth to function and comfort and allow the supporting structures to repair completely. So this is a basic objective for going for a endodontic treatment, or taking a case for endodontic treatment, taking up a case for endodontic treatment, to perform endodontic therapy in order to return the treated tooth to function and comfort and to allow the supporting structures to repair completely. Now, what are the indications for retreatment? Periapical radiolucencies that have not decreased in size after 4 years. That's the first criteria. Or for going for retreatment, that's the first indication. If you find that periapical radiolucencies on radiographs that have not decreased in size after 4 years. When you compare the pre-treatment radiograph with the post-treatment radiograph taken at a period of 4 years, if you find that the radiolucency is still at the same size after 4 years, so that's an indication for retreatment. Then tenderness to percussion. If your treated tooth is tender to percussion, that's an indication. Then apical pain to pressure. When you apply some pressure on the tooth, there is an apical pain that is felt for the patient. That's an indication for retreatment. Then fistula formation associated with the treated tooth shows that still there is some infection that is not managed properly, or later that has been reinfected, so leading to a fistula formation. So that's an indication for retreatment. Swelling of soft tissue. Swelling or soft tissue. Swelling of the soft tissue is also an important indication. Incomplete root canal filling for prosthetic restoration, even being asymptomatic. So even if you find that the treated tooth is asymptomatic, if you find an associated incomplete root canal filling just before going for a prosthetic restoration, that's an indication for retreatment. Now coming to the factors influencing restoration removal. So what are the factors that influence restoration